Everybody, and welcome back to another episode of Hybrid Healing Hour. Today we are going to be discussing two common genetic risk factors for cardiovascular disease that you may never have heard of. It's familial hypercholesterolemia and Lp(a). We are welcoming back our very special guest, Dr. Seth Baum. Dr. Seth Baum is a preventive cardiologist, a past president of the American Society for Preventive Cardiology, and the chief scientific officer for Flourish Research. So welcome back. Thank you for coming again.
Well, thank you for having me again.
And before we dive into this, I wanted to kind of talk about cholesterol. As you can see, it's in familial hypercholesterolemia, which we also call FH, which I will be saying today because I cannot repeat that word several times. So I want to dive into cholesterol a little bit and how it is processed in the body, particularly the liver, because I think a lot of people assume and associate with cholesterol with what we eat.
That's a great question. So first of all, it's important to know cholesterol is incredibly important. Every cell in our body has cholesterol. Every cell needs cholesterol, and every cell can actually make cholesterol. Every single cell in our body can manufacture its own cholesterol. That's very important to understand at first. We do consume cholesterol as well. So cholesterol has two sources. One, we make it, and the other, we consume it. People also think that cholesterol just travels freely in the blood, but it turns out that cholesterol is a fat and the blood is aqueous, meaning water-based. And if you think about making salad dressing, water and oil don't really mix well together. You get little bubbles. So if that were to happen in the blood, if you had little bubbles of cholesterol or fat, it would be incompatible with life. We would die. So the body smartly has substances that will traffic cholesterol around the body. And these are called lipoprotein particles. And you've heard of some of them. Mm-hmm. You, of course, but I'm talking about patients, have heard of some of them. You've heard of LDL, or low-density lipoprotein, and HDL, or high-density lipoprotein. There are a couple of others as well. The important thing to know is that these lipoprotein particles, these carriers of cholesterol that traffic cholesterol around the body, have different functions, different purposes in the body, but the cholesterol they carry is the same. So when people say, oh, my HDL is my good cholesterol, my LDL is my bad cholesterol, it's not true. Cholesterol is cholesterol is cholesterol. It's the carrier that has the beneficial or bad attributes. So what does this really mean? Well, the LDL, it turns out, low-density lipoprotein particles, carry cholesterol solely to get the cholesterol out of the body. They're like garbage trucks. The more of these garbage trucks we have, the worse off we are, because they tend, imagine them as little circles, little spheres traveling around the bloodstream, and they interact with the blood vessel walls. They bang into the arterial walls. And the more of them there are, the more likely they will be to penetrate underneath the inner surface of the vessel and cause a plaque. And those are the plaques that lead to heart attacks and stroke and other diseases as well. So we want to keep those levels of LDL low. The liver, which makes cholesterol too, is also our friend when it comes to degrading or getting rid of the cholesterol. What the liver does is on all of the liver cells, there are these receptors, these little arms, if you will, little hands sticking out. And the receptors will bind the LDL particles, those little spheres that are the bad ones, right? Not the cholesterol being bad, but the sphere itself having bad attributes, and will bring the LDL particles internally into the cell where the LDL particle is degraded and then the cholesterol is dumped out of the body, really ultimately through our GI tract. Mm-hmm. So that's what how LDL is being handled by the body. HDL, interestingly, is known as the good cholesterol because it helps take cholesterol out of blood vessel walls. It's very, very complex, though. We don't fully understand HDL, and all of our attempts to date to increase HDL as a means of decreasing heart attacks and strokes, all those attempts have failed. So we can't, at this point, we can't increase HDL and cause a benefit. Similarly and related, a risk factor for heart disease is a low HDL. So a low HDL, particularly when identified earlier in life, is a risk factor for what's called premature heart disease, early heart disease. So just important to know as a potential warning that if you have a very low HDL or a low HDL, you may be at risk for early heart disease.
And I know we're not talking about just cholesterol today, but you kind of triggered a question I have. So I feel back in the day, a lot of, I heard medical providers say, oh, well, if your HDL is that high, then it overrides the LDL being high. And I'm like, no.
Yeah, and you're right. And a lot of people still say that.
Yeah.
It was so ingrained in our understanding and our literature that HDL could compensate for, high HDL could compensate for an elevated LDL, that it's hard to undo that. The reality is that's not true. There are even some genetically elevated HDL conditions that have a higher risk of cardiovascular disease. So HDL does not protect you. All of our focus with regard to cholesterol should, at this point, be on LDL. We also have triglycerides. We're learning more about them, but currently, LDL is the evil one. High LDL causes vascular disease. We used to call it the LDL hypothesis. It's not. We have study after study after study that demonstrate the same thing. High LDL causes vascular disease, causes heart attack, causes stroke, causes peripheral arterial disease. Reducing LDL decreases the risk of those events.
And you also explained something very well that we hear a lot from patients and from things they read online, that cholesterol is necessary. You need cholesterol for life. We're not talking about lowering cholesterol. We're talking about lowering cholesterol transport molecules.
Correct. We're talking, well, ultimately you will lower cholesterol, but what we're not talking about is eliminating the capacity of a given organ to make the cholesterol it needs. And the most important one that people refer to is the brain, because the brain requires so much cholesterol. And so I hear this all the time, well, if my LDL is super low, my brain's not going to get nourished in cholesterol. A couple of things about that. Number one, LDL does not supply cholesterol to any tissue in the body. So it doesn't do that. Number two, even if it did do that, LDL can't cross the blood-brain barrier. So we have a barrier that separates the systemic blood, the blood in our body, from the blood in our brain. And that barrier is important because it protects the brain. LDL can't cross it, doesn't make it across. The only time it makes it across is in elderly patients when the blood-brain barrier starts to be less functional, and that's a bad thing when they cross. The other thing is the brain avidly can manufacture its own cholesterol. It does not need any outside source of cholesterol. So your cholesterol, your LDL could be zero, and your brain is just fine.
I'm really glad you touched on that, because we do a lot of more functional medicine in our office too, and holistic. And that's something that a lot of people are terrified to start statins or to go too low with their LDL. And we know you're born with an LDL of about 20 when you're right. Yeah. And is there anything wrong with getting it down that low?
There is nothing wrong. And if you think, what is the most important thing that happens early in life during both the fetal period and the first 2+ years of life? It's brain development. It's neural development. That's what the baby's doing. It's growing its brain. It's growing its peripheral nervous system as well. So if we're born with an LDL as low as 20 or 30, it would make absolutely no sense, biologically and from an evolutionary standpoint, for cholesterol to be a requirement for brain growth. So it really makes no sense. I understand why people say what they say, why people are afraid, but it really makes no plausible physiologic sense to worry about reducing LDL cholesterol and causing a problem with the brain. And we've looked at this in a number of studies, in giant studies, where we've looked at thousands of patients with LDLs as under 25 even, and there's no signal of harm for brain issues, cognitive issues, nothing.
So now that we've talked about no harm in low cholesterol, let's jump to one of our genetic conditions, familial hypercholesterolemia with high LDL. Can you explain to our audience what FH is?
Yeah, sure. First, I'm going to put in a plug here for the Family Heart Foundation. Oh. So, because we're about to discuss FH and Lp(a). And the Family Heart Foundation is a foundation that was started over 10 years ago and addresses these two genetic issues in a very effective way. And you should look at them online. They're a great resource. A lot of publications come out of them. They have advocacy arm, research arm. They started the only registry in the country for FH. So just very important to recognize them and full transparency. I am the vice chair of the board of that organization, but there are many, many other people, including somebody named Catherine Weilman, who started the organization, and it's been immensely effective.
I'll be sure to post that in the show description.
Please. So FH. So what is familial hypercholesterolemia? We touched on the LDL receptor, that little arm with the hand in the liver cells that brings the LDL particles internally into the cell for degradation and then disposal through the gut of cholesterol. There are certain genetic disorders of that receptor or of elements in the LDL particle itself, and then in something else called PCSK9, which we can get into later maybe, that can lead to a condition where that receptor doesn't function well. And if that receptor doesn't function well, you can imagine what happens. The receptor's whole purpose is to pull those particles internally, to destroy them, to decrease LDL. If it's not functioning, what happens? LDL rises. It's high. In this genetic disorder, and there are two forms of it, both are bad, by the way, but one is called heterozygous, where there's one mutation from one parent, and the other is homozygous, where two mutations are transferred down to the baby, to the child, one from mom, one from dad. Homozygous FH is worse in general than heterozygous FH. There are two mutations. LDL levels can be 5, 6, 7, 800. LDL, not total cholesterol, LDL levels. Wow. In heterozygous FH, one mutation from one parent, levels typically exceed 190, and certainly in the most severe of these patients can be in the 300s with that single mutation. We used to think this was incredibly rare, and we've learned, as we've learned more about genetics and more about this disease, that it's actually very common. The heterozygous form occurs in about 1 in 200 or 225 individuals. What that means from a clinical practice standpoint, every single practice, because practices have more than 225 patients, every practice has patients with FH in them. Until recently, until the Family Heart Foundation did a lot of work in this, those patients, 99% of them were hidden. The doctors didn't know. 99%.
Wow.
Until about 6-7 years ago. Now, probably 60 or 70% are still undiagnosed. Still not a great number, but a heck of a lot better than 99%. So that's very common. 1 in 200, 1 in 225. Homozygous FH is ultra rare. So that we used to think it was 1 in a million. It's probably closer to 1 in 300,000. Yeah.
Wow. I mean, and think about, like, in our practice, we have a lot of families, right? So if we have the mom and dad who, or mom or dad have it, then we definitely need to be screening the children. And I don't know if a lot of practices out there are thinking about that.
Well, you're thinking very well about this. So there's something called cascade screening. If we identify a proband or the index case, meaning that first patient in our practice who we say, oh, you have FH, and we should talk about how to make that diagnosis. I'll do that in a second. But once you identify that person, you're really obligated to cascade screen to look at every first degree relative of that individual to see whether those other relatives have it as well. because early detection and aggressive treatment are the way we can reduce risk in the FH patient. What happens, we've spoken about LDL getting into the arterial walls. So what happens with these super high LDL levels? Vascular disease is premature. It's very aggressive. Heart attacks and strokes occur at young ages. In the homozygous patient population, kids as young as 5 can die of heart attacks, 5 years
Wow.
old. Yeah. So it's a very, very serious thing. We need to identify these patients early on in life. If we look at diagnosing heterozygous FH, that 190 is the figure we use. There are 2 ways to do this. One is clinically, and the other is through the genetics. If we do it clinically, we look at a baseline LDL that exceeds 190 with a family history of premature heart disease or a family history of a parent or other first-degree relative with very high LDL levels in the FH range.
When you say premature heart disease, are we saying heart attack or stroke under the age of 50? Or what's considered premature?
So in men under 55, women under 65.
Okay.
Yep.
And there are some visible findings in people with FH as well, right? Things that you can actually see, unlike other cholesterol problems where you don't really see them unless you look at the blood.
There are. So there are things called xanthomas that typically lie on the tendons or in areas on the hand, the palms of the hand, between the fingers, that when we see these, we need to think FH. They're not that common, though. So it turns out that most patients with FH, certainly heterozygous FH, don't experience xanthomas. One of the ones that does happen and is often missed is a Achilles tendon xanthoma. And so when we examine patients, it's important to feel the Achilles tendon, just to feel the thickness. Sometimes you'll recognize, the more you feel, the more you know what a normal Achilles tendon feels like. It should be a very thin, strand. When you start feeling a very thick one or a lumpy, bumpy one, that could be a xanthoma.
So it's not necessarily something visible on the Achilles.
No,
because I know
it's
I think
not
of
visible.
when I think of them around, like you can see them on the eye, correct? Like, and those are more visible.
That's called xanthelasma.
Okay.
So the xanthelasma, which is in the corner of the eye, and interestingly, if you look at the Mona Lisa, she has xanthelasma, and she also has some xanthomas on her hands. So we think that Mona Lisa had FH, believe it or not. But the xanthelasma in the corner of the eye is not necessarily a byproduct of FH.
Right.
So that can just happen normally with normal aging. There's something called the corneal arcus, though. So corneal arcus means around the perimeter of the eye, around the iris, you see this graying that shouldn't be there. And if that occurs under the age of 45, that's actually pathognomonic, meaning it's a diagnostic for FH. So that's important to look at as well. Yeah.
And I do think that our pediatrician colleagues should also be maybe more aggressively screening their kids who have family histories.
And that's in our guidelines, and you touch on a very important point. At this point, the pediatricians are, and not all pediatricians, but a lot of pediatricians are not screening their kids according to our guidelines. If a child has a family history, certainly if it has a family history on both sides of high cholesterol or FH, that child should be screened by the time he's 2. Okay. So that's what we call a targeted screening. There are a couple of other points of targeted screening in children, 6 to 8, a little older than that. If they have hypertension or diabetes, we should target screen them. So those are our riskiest patients. There's also something called universal screening when everybody should be checked, and that is 9 to 11. And oftentimes kids will not have their cholesterol checked between 9 to 11. And the reason is you don't want anybody to be missed. So every child should have a lipid test done at 9 to 11. And then again at around 20, everybody. That's universal screening. Yeah.
Yeah, I know. I see a lot of the younger people in our practice, and get them in from the pediatrician, and it's amazing when I say, when's the last time you had the blood work done? They're like, not sure. Like nobody even thinks, they're like, I don't recall getting blood work done or whatnot, So I'm like, well, we're going to get a baseline.
It's a problem in the training, education and training of the pediatricians, even the pediatric cardiologists. I've spoken to a number of them about this, and most pediatric cardiology programs don't have exposure to lipids. The most I've heard is 1 month of addressing lipid issues. 1 month in a training program. So it's de-emphasized, and we're trying to change that.
I think one of the concerns also with them is that once they find a kid with high cholesterol, what are they going to do about it? Right?
And that is a problem because they're understandably they really don't have much experience treating lipids. So typically what they should do, and it's happened enough times with me that I think a lot of them are doing it, is if they test and it's high, they call a lipid specialist or a preventive cardiologist, adult cardiologist. So I've seen kids, to help the pediatrician, I've seen kids as young as 18 months, just for the purpose of helping manage lipids. Yeah.
Well, kind of going along those lines, I mean, there's not very many treatment options out there for adults. Is any of the treatment options available also approved for children with
So
FH?
some of them are approved for children. And it depends on the age, it depends on the disease state. So for heterozygous FH, we do have a number of choices. And we should make another distinction. There's so much to this, but we should make another distinction here. So we spoke about the LDL receptor and the importance of the LDL receptor and the fact that in FH, there's a problem with the LDL receptor. It doesn't work as well. In heterozygous FH, there are enough good LDL receptors, because remember, the mutation's only on one side of the family, that LDL receptors function adequately when they're upregulated. What that means is if you get the body to make more of these receptors, you can drop the LDL significantly. And almost all of our lipid-lowering drugs, the statins, ezetimibe, the PCSK9 inhibitors, all of those function by upregulating the LDL receptor. So we make more of the receptors and we drop the LDL down that way. In heterozygous FH, again, because there's only one mutation, those drugs are effective. And you can really, reduce LDL to very low levels, almost like in some ways, like a non-affected individual. In homozygous FH, it's a different story. And there are two types of homozygous FH receptor mutations, LDL receptor mutations. One is called null or negative. And in that mutation, the receptor has less than 2% effectiveness. And in the other one, where it's just a less effective receptor, it's 2 to 25% effectiveness. So in the ones with null receptors, you can upregulate LDL receptors all day long, and you're just not going to have any benefit from the medications. There are a couple of medicines specifically for homozygous familial hypercholesterolemia, though, that work independent of the LDL receptor, and they are very effective. And these are recent developments.
Are they FDA approved right now?
FDA approved. And we were in, we were in the studies actually. The most recent one is called evinacumab, again, only for homozygous FH, and in studies has demonstrated a very significant reduction in LDL in these homozygous FH patients, the hardest patients to treat, 50% reduction in LDL. Yeah.
And there is a non-pharmacological treatment as well, right? Do you want to touch on that?
Thank you for reminding me. You're right, and I should not miss talking about that. Thank you. It's called LDL apheresis or lipoprotein apheresis, and it's a technique that patients undergo every couple of weeks, where we actually remove the LDL from their body. So it requires a machine. It's like a dialysis machine, and you're a nephrologist, so you've been down that road a lot. Like a dialysis machine, without the negative effects of dialysis. Dialysis, you could tell me far more than I know about this, but it makes people weak and tired, and they just don't feel great. They often drop their blood pressure. This doesn't have that effect. It cleanses the blood of LDL and also Lp(a), which we'll discuss, and it is FDA approved. This has been an approved therapeutic since the 90s, actually, in the United States. So, and we have a program in Boca Raton where we do that procedure on these very high risk patients.
And it's still relatively unknown, though.
It is relatively unknown. As I was about to not even talk about it, so now you see why it's relatively unknown. So thanks for bringing that up.
The amazing thing about cholesterol is most people say, "Oh, you don't feel it when your cholesterol is high," but these people actually feel it when you take their cholesterol out. Right? They feel great.
They do tend to feel better. They do. And it's interesting, in that procedure, there are a lot of other things that happen that we don't really focus on, removing pro-inflammatory substances. It may have effects well beyond the lipid-lowering effects and the lipoprotein-lowering effects that it has.
I was actually going to ask that. So has it been proven with this group of people that by lowering the LDL, it does significantly reduce their risk of cardiovascular disease?
It's a great question. It has not been proven with the standard type of study that we've done, that we typically do, which is that randomized, double-blind, placebo-controlled study. It has been proven when patients are used as their own controls, meaning a patient has, a stent every year, goes on apheresis, and all of a sudden is not getting any more stents, or has had a visible progression of disease based upon, angiography, and then that, changes. We've shown that in different ways, but it hasn't. The standard study has not been done, and it's not been done because there are very few, of these patients. There are not enough patients to do that kind of trial, and the patients, frankly, are so sick that you don't want to put them in that kind of trial. By the same token, these other therapeutics that I mentioned that are the pharmacologic therapeutics, they have not had those studies done either. Too few patients. You just can't do it. It's not practical.
Right.
So we accept the fact that we know that LDL causes disease, and we know that LDL reduction reduces disease. And we do make that extrapolation that when you start with a super high LDL level and you drop it very significantly, even if you haven't put the patients in an outcomes trial, we rely on all the other data that we've accumulated to say it's gonna be good.
Does having other cardiovascular risks increase your chances of FH, like ApoE or Lp(a)?
So other no, and so other cardiovascular risks don't increase the risk of having FH. Lp(a) is a little different. I'll explain that in a second, but it doesn't increase the risk. But other cardiovascular risks, hypertension, diabetes, elevated Lp(a), in conjunction with FH are bad. So that becomes cumulative. That becomes a problem. So you always want to reduce all other cardiovascular risks in a patient with FH. Lp(a) is a little different because elevated Lp(a) is a little more prevalent among patients with FH. So there is a little bit of a connection there.
Who do you recommend to get genetically tested for FH, who have the genetic screening done?
It's a great question, and I was part of a paper in JACC, the Journal of the American College of Cardiology, a few years ago, where it was a very large group, and we basically sat around and discussed this very issue, and concluded that it's always good to get genetic testing. So whenever you suspect FH, it's good to do it. The problem is, though, that people have to understand that we have an expression, phenotype trumps genotype. And what that means is if you make a clinical diagnosis of FH, patient with a strong family history of high cholesterol and premature heart disease, patient has an LDL of 220, patient has already developed vascular disease at a young age, we call that person a patient with FH. You then go and do genetic testing on the patient, and you don't identify a mutation. What does that patient have? Has FH. Okay.
You're not going to let that person walk on the street without treating him for FH, right?
Well, and looking at him as though he has FH. So he does have FH. He just doesn't have a genotype proven FH. He's got a phenotype proven FH. Clinically, he's got it. And that's because we have not identified all of the mutations yet that cause FH. And we know there are more out there. We've identified over 2,000, but it keeps accumulating. Every year we identify more and more of these mutations. So we're not going to ignore a disease just because we don't have the capacity or capability of identifying the mutation.
And once you're diagnosed with FH, the coverage for the drugs that treat FH is pretty good. We don't have a lot of trouble getting patients the medicines they need once they're diagnosed.
And that's a very good point. So you don't want, if there is an insurance issue, and that can be an issue in homozygous FH as well. If there's an insurance issue, you don't want to damage the patient by having a genetic test that doesn't show FH and then say, the patient doesn't have FH. If the patient clinically has FH, the patient has FH, regardless of what the genetics show.
You would do more harm by not treating.
Correct.
So, well, shall we talk about Lp(a)?
We can. Okay.
So what is Lp(a)? Because I always describe it as like a tail attached to the LDL particle, and that tail, I describe it more like a hook in a sense, can cause damage. But I want to hear your description.
Yeah. So, and it's not necessarily the tail, but that causes the problem. It's maybe a couple other things, but. So yes, it's like a very small LDL particle with this tail that's called ApoA, and thus Lp(a), that's attached to it, and the tail can be different sizes: long tail, small tail. The particle is what we call a triple threat. It's got three aspects that make it particularly dangerous. One, it causes vascular disease, so it's like LDL. It can cause plaque, and that plaque can lead to a heart attack. Two, it's highly pro-inflammatory. There are phospholipids in the surface that are pro-inflammatory phospholipids. That's probably the biggest problem with it. But it also has an element that is prothrombotic. And that's associated with the tail as well. What happens in a heart attack? In a heart attack, you have a plaque. The plaque typically will be vulnerable if you're going to have a heart attack. It's got what's called a thin cap, that little covering fissures like an earthquake.
Would we say that's soft?
Soft plaque. Yes. It can fissure and basically expose to the blood the inside of that plaque. And that inside of the plaque is highly inflamed and is prothrombotic. It causes a thrombus to form. So the elements, those three elements, the plaque, Lp(a) causes, the inflammation, Lp(a) causes, the clot, Lp(a) causes. So you can understand why it can lead to a heart attack. All the elements that cause heart attack are embedded in the Lp(a) particle.
So we've, I guess, more recently been having more awareness of Lp(a), and we know it is, because of that, an independent risk factor for heart disease, correct?
Correct. It is an independent risk factor for heart disease, heart attack, stroke, peripheral arterial disease. It's also highly prevalent. 20% of the Caucasians have an elevated Lp(a). 30+% of blacks have an elevated Lp(a).
Wow.
Yet I would say that most people have never had their Lp(a) checked.
Most people have never had their Lp(a) checked. South Asians have a higher incidence of Lp(a) as well, by the way. So, but if you think about prevalence like that, why are we not checking Lp(a)? Recently, we've had European guidelines, we've had Canadian guidelines that have stipulated that everybody should have the Lp(a) checked at least once. Recently, the National Lipid Association just added that to their guideline. Currently, our major guidelines for the American College of Cardiology, American Heart Association do not make that recommendation. Most of us in the field test our patients. and it's particularly so. It used to be, why the pushback we got from clinicians about testing Lp(a) was, why should I test the Lp(a)? There's nothing I can do about it. Well, you just brought up the apheresis, the lipoprotein apheresis. There is something you can do about it. That's approved for Lp(a). So that's one thing. The other thing is, it's always good to understand the patient's risk. And if you identify that risk, the patient most likely will be more prone to decreasing unhealthful eating, to maintaining an optimal weight, to ensuring that blood pressure is well controlled, to exercising regularly. So all of those other risk factors can be better controlled if the patient knows that the patient has a significant risk. The other thing is that there are a number of drugs in development right now for Lp(a). There are clinical trials that these patients can be in. And within a couple of years, we should have a therapeutic that can help reduce Lp(a).
I'm excited for that.
Me too.
And so let's talk about how you can check for Lp(a). Unfortunately, it seems that there is a lack of standardization.
That's a good question. There is, but we're getting much closer to standardization, and we're heading toward looking at it in nanomoles per liter, not milligrams per deciliter. And that's the one where the cut point is 75 nanomoles, and when you're between that, between 125 and 175, you're sort of in a moderately elevated range. Over 175, you're in a worse position. So that's becoming more standard now.
And I think Quest checks it in nanomoles.
Quest, I believe, does. Yes.
Yeah. So that's easy for any of our audience to request from their primary care or their physician provider.
Right.
And so speaking about treatment options. So at what point, what if somebody's just above the cusp? Say their Lp(a) is like 82 or 90, so they're moderate risk, but is that somebody you would fight to get started on treatment right away, or do you just work to get the LDL down as low as possible? Both? What do you recommend?
So we have this saying, you treat according to risk. So the highest risk patients, we give the most therapeutics to reduce their risk. So in the case of Lp(a), the first approach always is to reduce. In the case of Lp(a), where the patient's at high risk, okay, meaning the patient has a family history of heart disease, has had heart disease, has a coronary CT angiogram that demonstrates soft plaque that you mentioned. So a higher risk patient with elevated Lp(a), you always try to get the LDL down as low as you can. Okay?
Which is recommended less than 55, correct?
Well, so that's a guideline through the American Heart Association and American College of Cardiology. That 55 really is for people who are what are called very high risk. So they've had a heart attack or a stroke or peripheral arterial disease, and a couple other risk factors as well.
Like diabetes.
Hypertension, smoking, there are 9 of them, I believe. Kidney disease, heart failure. But anyway, so that's the guideline. We don't always have to practice according to the guideline. The guidelines are just guidelines. So for me, if somebody were to have, for my patients, I can't speak to anybody else's patients, but if somebody were to have, a high risk, not fall in that very high risk category, and have elevated Lp(a), I would drive the LDL as low as possible. And 55 is not a magic number, by the way. It's just, and nor is 70 that we use as well. And those goalposts, as you can see, keep moving, and they're moving down because we know that reducing LDL more and more and more is going to reduce risk. So you can use that number, but the idea is just get that LDL down.
Gotcha.
Is it an independent risk factor? So if someone has a really good LDL and few other risks, but yet they have a high Lp(a),
yes,
will it stand by itself?
It does. Yep. Okay. And the higher it is, the worse it is. So you asked about the 82, definitely a lower risk than a 400. A 400, higher risk. But just because you have a 400 doesn't mean you're going to have disease, though. Right. But you have to recognize you are at risk.
And you get some Lp(a) lowering by PCSK9 drugs and inclisiran as well, right?
You can. So the studies on PCSK9 inhibitors and inclisiran have shown a reduction in Lp(a) in the 25 to 30% range, but it's not uniform. So some people might have a 50% reduction, other people 0. So that's pretty much the way that works. You can't count on a 30% reduction.
But there is a new drug in clinical trials that has a significant reduction.
So there are a few new drugs in clinical trials, from one that's an 80% reduction in Lp(a). The next one in line is 95 to 99% reduction
Wow.
in Lp(a). So yes, we've found therapeutics that are highly effective at reducing Lp(a).
Well, on top of that, though, are they, just because they can lower the number, are they proven to reduce your risk for cardiovascular disease?
And that's a great question. And the answer is not yet. So the trials that these drugs are currently in, and again, are Flourish Research or Flourish Boca Raton is conducting these trials. There are phase 3 trials that are called cardiovascular outcomes trials, and they will answer that question. That's what they're for.
Awesome.
These are international studies. They're very large studies, 10,000 patients or so, and they take years to complete. But they will answer that question, that very important question.
I can't wait for that
Yeah.
data.
Yeah.
So what about aspirin? Is there any benefit to taking aspirin when somebody has a elevated Lp(a)?
So I believe there is, and we have some data to support that. And knowing about the prothrombotic or the clotting enhancing aspect of Lp(a), again, this is not a sweeping statement for people who are out there listening. I can't make any medical recommendations for anybody listening to this. But in my patients, who have very high Lp(a)s, often I will use aspirin.
But, okay, so now we're going to talk about aspirin, because I get asked a lot of questions with this. Is the half-life of aspirin long enough to do any benefit for protection? And what if people have the bruising and then they go to take it like every other day or twice a week? Is that still beneficial?
It's a great question. And aspirin's tricky. Aspirin's half-life is very, very short. It's very short. So aspirin's out of the body in an hour, hour and a half, something like that. Its effect on platelets, which is how it works, is durable, right? So it has its impact on a platelet, and it's a permanent impact. But we're making platelets in huge volumes. So by the end of the day, you basically have nearly replaced your platelets, right? So the aspirin effect is significantly diminished. I think we don't completely know how to. I know it's such an old drug, and we should know this. I don't think we fully understand how best to use aspirin at this point.
I would say that too. I mean, that's you get an article one year saying you need to be on aspirin, and you think anybody over the age of 55 should, and then it reduces stroke, but then they say no, and
it's bleeding.
Yes.
Right? So it's a problem. We're still dealing with it. I imagine over the next several years there'll be more aspirin studies, and the narrative will change.
So this has been extremely helpful. I think I got a lot out of this as well. And I think your explanation of lipid transport molecules was one of the best explanations I've ever heard.
Well, thank you.
So I hope that everybody who has any cholesterol issues listens to that.
And if you're interested in learning more about the clinical trials that Dr. Seth Baum has mentioned here today, go back and listen to our clinical trials podcast.
And do you want to give them the website for Flourish again?
Sure. It's flourishresearch.com, FLOURISH research.com.
Perfect.
Thanks.
Thank you so much for coming on.
Thank you.
Thank you.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.